Hi everyone, I'm Rose Gerber, the Director of Patient Advocacy and Education for the Community Oncology Alliance. For those of you who are returning guests, thank you for joining us again. I hope that you're finding these short, quick advocacy sessions useful and informative and applicable in your own advocacy and oncology work. And if you're a first-time guest, an extra special welcome to you. Before I introduce our special guest, Dr. Barbara McInerney, who's going to talk about white bagging and brown bagging, I'm going to take a few minutes to give you some highlights from our own organization, COA, the Community Oncology Alliance, and COA's Patient Advocacy Network, CPAN. One of the main things that we do as a network of oncologists and the patients they care for is to try to stay on top of national oncology news that could affect patient care. And when we all experienced COVID-19, specifically the quarantine, one of the first things that our oncologists did was they became very, very concerned about the patients that were under their care, because as we all know, as difficult as this was for all of us, there's no one more vulnerable than a patient in treatment, especially cancer treatment. So what our oncologists did is they quickly adopted telehealth as a safe way to care for their patients, continuing to care for their patients, or if they were already using telehealth, they increased their usage. And now that we're continuing to live during the pandemic, our organization has issued a statement on our recommendations for patient care and telehealth going forward. And you can find that information by looking at the address on this slide, www.communityoncology.org. And also when you do get to our website, there's a ton of great information, but I would like you to also take a few minutes and click on the advocacy tab. You can learn a little bit more about CPAN. And when you start poking around the CPAN site, you'll find a recently released newsletter. In fact, we released it last week, and hopefully many of you are already on that email list. Take a few minutes to read it. It has some great information and again, some helpful resources for you. Now, it is truly an honor to introduce Dr. Barbara McAneny. Many of you know her. For those of you who don't, I'm going to give you a very quick snapshot of her impressive history. She is a practicing medical oncologist in Albuquerque, New Mexico for the New Mexico Cancer Center. And by the way, New Mexico is known as the land of enchantment, just a little fun tidbit for you. Dr. McInerney also recently is the immediate past president of the very prestigious American Medical Association, the AMA. She's testified in front of Congress, and she's done an incredible amount of innovative work, and innovation is one of the things that she's known for. But when you do your own research on Dr. McInerney, one of the things that you'll come across is something that makes her really unique as a physician, is that she's not only an advocate for her patients, she's also an advocate for physicians. And that's really important because as cancer patients, as survivors, we're constantly told that it's always just about us, or we're patient-centric, and that is absolutely true. I've said it a lot of times, and I'll say it a lot of times going forward. But it's really important that physicians are able to take care of their patients. And one of the things that Dr. McInerney does extraordinarily well, whether it's in front of Congress or taking care of patients' bedside, is she tries to remove obstacles that come between a patient and their physician. And before I actually turn it over to Dr. McInerney, I want to say this to all the advocates on the call. And who's an advocate? An advocate is everybody from the CEO who sets the tone of their company, their agency, or the patient. What we're going to do today is we're going to learn about something new. And when you become an advocate, there's so many topics. You know, you can learn about the disease itself. You can learn about fundraising. There's just a million things you can do with an advocacy. But the main thing is to keep learning. So Dr. McInerney, I want to turn it over to you. We are all your students today. Think of this as a giant auditorium. You have over 500 people in the audience, and you're clearly an expert. So thank you, and please tell us everything we need to know and what we don't know about white bagging and brown bagging. Thank you, Barbara. Dr. McInerney.
Yeah, you can call me Barbara. Thank you very much, Rose, for that kind introduction, and thank you also to CPAN and to COA for all the work that you do. One thing I just want to say to the patient advocates on the call is please remember that doctor-patient relationship is a two-way street. You might feel attached to us. Let me tell you, we also feel very attached to you. And that's the reason that advocacy from patients working with doctors is so powerful, because it displays that relationship. Now, cancer doctors in particular are really, really interested in trying to figure out how to get you the best care we possibly can, but safely. We recognize and have recognized for many, many years that the chemotherapy drugs that we use and now the new immunotherapy drugs that we use are dangerous. They have side effects. They have things that we have to monitor and watch for, because cancer doesn't go away just because you want it to. It goes away when you make it go away. And that requires these chemotherapy drugs, it requires radiation therapy, it requires pretty drastic measures to try to get that cancer to go away. So many of us have set up processes to really work hard to make that as safe as we possibly can. We know that your blood counts often will go down, so we give you growth factors to bring them back up. Many of us have set up processes so that if you have any version of I'm sick or I don't feel well, we have a way to get to you and get you to us so that we can manage those problems before they become severe enough to go to the hospital. So part of what we've done to deliver these drugs very, very safely is created infusion centers. So I'll give you a little bit of history. When I was starting out as a brand new baby oncologist, we didn't have very good anti-nausea drugs. Patients felt terrible getting chemotherapy. And so every Monday I would admit a bunch of patients to the hospital. I would give them anti-nausea drugs that sedated them, give them their chemotherapy, wake them up on Thursday and let them go home on Friday. And that's how chemotherapy was given back in the olden days. Fortunately, those are the olden days, and now we have really good anti-nausea medicine so that we can give people chemotherapy, not wipe out a week of their life and sedate them to get it, but they sit in an infusion center, they get their drugs, and then they go home to their families. And that's as it should be. So part of creating that safety process is setting up infusion centers and employing oncology certified nurses, who many of you have come in contact with. These are nurses who take oncology to heart, and they understand that these drugs have to be delivered in an extremely safe fashion. That's why you see our nurses dressed up in these chemotherapy gowns, which now, by the way, are doubling as PPE around the practice to take care of COVID patients. But you see them putting on the gloves, you see them doing all this. This is there to protect themselves, but it's also there to protect you as a patient. You'll notice in most infusion centers that there's a special contraption called a hood, which allows the pharmacist to mix those drugs in a way that the pharmacist is not inhaling the drugs that they're mixing, because that would cause harm to them. And that they're being very precise about how much they mix, how fast it goes. All of those things are patient safety issues, because you want us to take all of those precautions and make sure that we have what's called USP 800 compliant pharmacies to mix those drugs so that we don't have to worry about contamination. The other thing that happens with patients routinely is you come in to see your doctor and they say, oh, well, your blood counts dropped a little bit too low, so I want to decrease your dose. Or sometimes you hear, this one isn't working, I want to change it to something else. In either of those situations, what we have in most oncology practices is the ability to change your drug dose on a moment's notice. So we've set up a very efficient system. They refer to it as buy and bill, because we buy the chemotherapy drugs, we stock them so that we have what you will need when you come in, and we administer them to you using oncology nurse professionals. And then we bill your insurance company or your Medicare, whatever your payer is. And then we wait usually about a month to get paid for the drugs we bought. So that's buy and bill. So one of the issues now that people are interested in trying to do is a thing called white bagging. Because what the insurance companies would really like to be able to do is to deliver this drug to us in a little white bag so that if I'm treating Barbara McAneny today, I get Barbara's drugs in a little white bag. And then what does that mean that I do? It means that I have to take that drug out and the dose is already predetermined. But it also means I don't know where that drug has been. Somebody sent that to me. Usually when we purchase the drugs, we have what we call a pedigree for the drugs. We know when they left the manufacturer, we know where they've been, we know how they've been stored. Because some of these drugs, if you store them too hot or too cold, they don't work well. So we don't want to have that occur. So we're very careful. But if I receive the drugs in a little white bag, what do I know about that drug? I know that your insurance company sent it to me. I don't know where it's been before. I don't know whether it's been stored properly. I don't know if it was rejected by another clinic and then sent on to my clinic. That won't do. You know, that is our main concern about white bagging is I'm not certain of it. Plus, if you need a change in your dose, I have to ship that drug back to whoever sent it to me. I have to make you wait and reschedule for another day to get a different dose of chemotherapy. And that is remarkably inconvenient and sometimes even frightening for patients who, you know, if you have cancer, you want to get it treated. You want to be on top of this. So we don't like white bagging particularly. The insurance companies do it mostly for money, but I'll get to that in a bit. Now, what's brown bagging? We've labeled brown bag because some insurance companies want to deliver the drug to the patient, and then the patient brings the drug in a little brown bag and brings it to my office where we're supposed to mix it or inject it or whatever. Now, this compounds all of the problems that we have with white bagging. With brown bagging, I don't know where that drug has been, just like the white bag. I don't know who rejected it. But then I don't know, frankly, how you as a patient have managed it. When they're here in my office, they sit in a very temperature controlled refrigerator or a very secure location, so I know it's not been contaminated. Did it sit on your front porch for a day because you were out when they delivered it? Did the dog knock over the package and lick the bottle? I don't know. Did somebody see a package sitting on your front stoop and ran off with it? Because people do those things. So that becomes an issue for the patients because I don't know what has happened to that drug. I live in New Mexico. We're high altitude desert. We go from, 40 degrees at night to 80 degrees in the daytime. So did that drug sit on your front porch when it was 40 degrees outside and then sit there when it's 80 degrees outside? And then I'm supposed to inject it into my patients. For us, in my practice, we've just said, I don't think so. We are not going to put our patients at risk for doing those things. We are going to make sure that the product that we purchase from a manufacturer has been delivered in a quick time frame, has been stored in the proper place, and has been stored carefully so that that drug does not do what we call denaturing, which means just deteriorating. So it might not be as active as we all want it to be. So that's a very alarming idea, both white bagging and brown bagging.
Dr. McInerney,
Yes.
I just wanted to comment on what you just shared. It's incredible, like as patients, even if a patient, you've taken care of, thousands of patients over your career. A lot of patients, especially now with the internet, they're going to do a lot of homework and research before they go into your office, but it's just going to be on the basics of the disease usually. And this again just shows why it's so important that we just have this, many times this blind trust that you're going to be taking care of us. Because to be totally blunt, I'm sure there's a lot of patients, I might have been one of them, that if someone said, Rose, there's going to be a package delivered for you because everything's delivered now, that I just pick it up and not question it. But this is, why I'm so grateful that you're educating us, because it's even a learning experience for me. Like the example that you gave of, a pet, licking a bottle. My God, that's really nauseating. Or the way that a drug is stored. I've had the privilege of going to your cancer center in New Mexico and also cancer centers across the country, and I've seen the storage of drugs. And that's something that when I was a patient, and most patients, we don't think about it. Not that we need to, but when we're ready to become advocates, learning these things is really powerful. Please share more.
Sure. When you're a patient, I don't want you to have to think about these things.
Mm-hmm.
A patient should just have to focus on, how do I get well? What can I do to help myself get well? I don't want them to have to think about, is the environment in which I'm getting my drugs safe? Have these drugs been handled properly? That's my job. And we should do our part of it and not worry patients. When you become advocates, it's important to dig a little deeper into the care process and understand all the pitfalls, because they become ways for legislators or health plans to manipulate the process. So I want to talk a little bit about home care too. You know, the insurance companies these days are saying, oh, gee, this is wonderful. We just have our patients' convenience at heart, right? We just want our patients to be able to get, they actually don't call you a patient, they call you a covered life. But they want you to get your drug at home. Now, let's talk first about the patient's safety of that. So, especially in the time of COVID. So if you have in your house a family member who is going out to the grocery store and comes back, they may have been exposed to COVID, and we don't know that. So there I am delivering a drug to you in your home. And in the office, we have a exceptionally clean environment that makes it safe to do that. But frankly, there are a lot of patients where they're home, especially if you're sick, and cleaning, it takes a lot of work and effort, and your significant other is being your caregiver, making sure the house is sterile is not high on your list. But that means that we're delivering these drugs in a less than optimal environment. I don't mean to be insulting with the cleanliness of people's homes. I know everybody tries, but it's just not the same as in a clinic where we have staff wiping everything down with sanitizer and making sure that we have germ killing processes everywhere to make sure it's safe. The second place where patient safety is significantly threatened is if you have a reaction to that medicine. Now, most of you have been in a chemotherapy infusion suite, and you've been there either by yourself and had a reaction, or with other people and seen their reactions. And you know that as soon as a reaction occurs, the staff will go to help the nurse whose patient that is. And the physician will be there, or a nurse practitioner or a physician assistant, but someone will be there who knows, has the policies of how do we manage this particular reaction? What do I do? What drugs do I administer? We put into action a well-organized team. The primary nurse is watching you. The second person is going to get the drugs that you might need, like Benadryl or Decadron, to stop a reaction. We're checking your blood pressure. A lot of activity is going on. It takes a team. Mm-hmm. When you're getting a chemotherapy infusion in your home, you've got one nurse. Maybe you don't even have a family member caregiver there, but unless you happen to be married to a nurse or have your significant other be a nurse, you don't have a lot of extra staff around to help if something adverse happens to you. When those reactions occur, we can manage them. We can make sure that you stay safe. We can make sure that this doesn't have any lasting complications. If you're in your home and I have one nurse there, that's a problem. And some of the insurance companies want to just use routine home care nurses. Well, that really worries me. Nothing against home care nurses. They do a great job, but their training is to administer antibiotics, to help you with wound care after a surgery, to help people manage after a stroke. They are not trained in chemotherapy. They're not trained in how to safely administer it and manage it. So the idea of having a nurse who's not trained delivering chemotherapy frightens me as much as if you told me to go take out somebody's appendix. I'm not trained to do that. You sure don't want me doing that. So we need to be able to make sure that the staff is completely trained well. And then you think about people who are setting up this process. They say, okay, the insurance company tells us we're going to send out nurses to your home and make it convenient for the patient. Well, I think they must all live in affluent suburbs if they're considering that option. I'm in New Mexico. We don't have everybody living in affluent suburbs. We have people who are living an hour away from our clinic in very rural areas. We have some people who are living in less than optimal housing situations. Are we going to apply this to people who live in the inner city? And then we're going to send a nurse who more often than not is a young woman, and we're going to send her down the street with a bag of drugs through an area that is not safe. And what possibly could go wrong with that? So it's very worrisome to me, just for my staff purposes of being able to say, I'm going to send this person out. So therefore you would say, well, maybe we should send 2 people out every time, 1 person to be there to assist and 1 person to do the process. And then the 2 people can have each other's backs when they're walking from the car to the house, or when they're running around lost in a rural area trying to look for your house. That might work, I suppose, but then I'm paying 2 staff members for 1 infusion. And when that happens, who do you think ends up paying for that? Do you think that the insurance company is going to just take that cost and put it to their bottom line as their loss? No, they're going to raise their rates to cover that. They're going to charge more for that process, which kind of gets me to the economics of it. Insurance companies are really concerned that when we buy a product and then we give the product to a patient, and therefore they consider that selling it to the insurance company, that we're making too much money on that. Well, every practice needs a margin. Every business needs a margin. Even if you're selling apples, you can't sell the apple for exactly what you bought the apple for. So you're right, there is a markup on the drugs that covers the cost of the nurses and everything that happens in the business. So they would like to eliminate that by getting the doctors out of the buy and bill business so they can just charge what they want. Now, we know that insurance companies are making a huge amount of money on drugs. They complain bitterly of the cost of drugs, but studies we did working with the AMA showed that 42% of the cost of the drug occurs after it leaves the manufacturer. It's the insurance company markup, it's the pharmacy benefit manager markup, it's all kinds of markups going back and forth that add no value to the drugs, but they add a lot of profit to insurance companies, which is why they do this. So they would like to get those pesky doctors out of this equation so they can just control that entire economic market and be able to charge and pay exactly what they want without anybody else looking in on it. It also worries me for the practices. I've had some insurance companies assure me that they only want to do this for the very, very safe drugs. Well, if we have the infrastructure of this infusion center with nurses and pharmacists, all of whom, by the way, require salaries, and overhead and computers and electronic medical records and fancy hoods and pharmacies that are prepared, unfortunately, that's expensive. And I need to be able to have a certain volume of patients coming through that infusion center to be able to afford to hire those people, to be able to afford to have that overhead. So if the insurance companies can pull all the simple chemotherapies out of my practice and deliver them in another way, then my volume goes down, the amount of intensity of the drugs I'm administering starts to go up, and it becomes a difficulty for us to be able to afford to have that infusion center available for you. And that worries me for community oncology practices. We know that if you get your care from a hospital outpatient practice versus a community oncology practice, your price may be double because, and sometimes higher than that because of the difference in payments. If we lose community practices, which are the high quality, low cost alternative to hospital-based practices, then who ends up paying the difference? Whose copay will go up? Who will have a harder time getting their care? I believe very strongly that there's great value to community oncology practices that can structure everything we do around the needs of the patient. And if we lose that into a bigger hospital setting, I believe the ultimate losers will be patients who pay more for less personalized, less convenient service. So to wrap this up, the key to us being able to manage these problems and to be able to continue to provide a setting for you to get cancer care where you know us and we know you and we have that doctor-patient relationship together. It is so important that we work together to say, don't take away the patient safety, the staff safety policies that we have put in place simply so that the insurance companies can earn more money. This is the value of CPAN. This is the value of COA, is doctors and patients working together to make sure that cancer care remains safe and comfortable and convenient and effective for our patients. Thank you.
Thank you so much, Dr. McInerney. I want to go back to two comments that you made. When you painted that scenario of the at-home situation, again, this is one of these thought-provoking moments because, again, we're all, especially now the deeper we get into quarantine and COVID, is many people love the comfort of home. So anything that you can do in your home, I'm going to send a nurse, sounds great, but we don't think about the scenario that you described. And when you were telling that story, it really triggered a memory for me, and it probably triggered this in a lot of cancer survivors. I remember sitting in a chemo chair getting Herceptin, which was at that time an experimental drug, very long infusion. My husband was there, by my side. But and I was very conscious that I was taking an experimental drug. But I do remember, in addition to my husband, that yes, my oncologist came by and basically held my hand too. But there was a flurry of nurses from Eastern Connecticut Hematology just not necessarily taking care of me in particular, but just the busyness of the clinic. And yes, I guess in a lot of ways, without even realizing it, it was very comforting to have all those nurses running around versus putting the pressure of a family member, as you mentioned, who, unless you're lucky enough to be married to a nurse, you're not going to have that at home. And another comment that I want to make, and I really appreciate your candor with this, is community oncology clinics are small businesses. And again, educating, I've done a lot of education on this subject because it's so easy to go, oh, all doctors are rich doctors, they're charging us too much for drugs. But like you mentioned, there's a lot of things that we don't need to be worried about as patients and we shouldn't be worried about. But there's a lot of steps, the whole manufacturing, the whole product cycle before that drug gets to a patient. So I'm so grateful that you're an advocate, not just for cancer patients, cancer survivors, but for your fellow physicians as well. And congratulations on all your enormous, incredible work, Dr. McInerney. You really inspire all of us. Thank you again. And I'm gonna have the news now of our next topic. So if our wonderful team can advance the slide. Next slide, please. So again, thank you, Dr. McAneny. Thank you to all our listeners. And our next chat is going to be just as interesting. I'm very happy to share that we're going to have Shelley Fugnasso, who's the CEO of the National Coalition for Cancer Survivorship. And the great news is there's so many cancer survivors, and they do a great report every year called the 2020, or the changes by the year, by the way, the State of Cancer Survivorship Report. So please join us again next month, and thank you for your time today. Enjoy the rest of your day.